retinal detachment. It is the separation of neurosensory layers from rest of the layers, and the sign and symptoms includes floaters and flashes like curtain-like sensation falling in front of eye, and Schaffer's sign can be positive, which is tobacco dusting of the vitreous. So the classification of retinal detachment, it can be divided into basically three types. Three type of retinal detachment can be seen. One is rhegmatogenous, which is most common type. The next is exudative, and the third one is tractional type. So firstly we will discuss rhegmatogenous retinal detachment. The risk factors include myopia as the most common cause, and it can also occur due to post cataract surgery, and trauma can also be the reason. The patient uh, is predisposed to retinal detachment will have the following features like holes and lattices and tears, and post-traumatic surgery, post-cataract surgery, and trauma can be uh, also predisposed to this type of retinal detachment. The symptoms will include watermarks in chronic retinal detachment, wherein hyperpigmentation lines in the retina caused by deposition of pigmented epithelium can be seen. So next type is exudative retinal detachment. In this type of retinal detachment, there will be no hole or break or lattice in the retina. There will be shifting fluid, and there is sudden painless loss of vision. The causes includes malignant melanoma of the choroid, which is the most common cause of exudative retinal detachment, and it is the most common tumor of eye in the adults too. Other causes includes pregnancy-induced hypertension, choroiditis, malignant hypertension, and VKH syndrome. So the last type is tractional retinal detachment. It is slow, painless loss of vision. The causes include diabetes mellitus, which is the most common cause. Other causes are sickle cell anemia, retinopathy of prematurity, and retinal vein occlusion. Investigations done are fundus examination, which includes indirect ophthalmoscopy, optical coherence, tomography, OCT, and B scan or USG. The treatment involves basically in 48 to 72 hours, a photoreceptor starts dying, so we need to do it a bit faster. So treatment part includes cryopexy and laser photocoagulation. Buckling can be done, and also pars plana vitrectomy can also be done, and pneumatic retinopexy can also be done. So next comes the diabetic retinopathy, similar type of topic, in which that there will be damage to the retina due to any systemic disease, and the patient presents with a blurred vision, fluctuating vision, and impaired color vision, and also complaints of floaters and redness. So the classification part, there it is divided into two types. One is NPDR, that is non-proliferative diabetic retinopathy, and next one is PDR, that is proliferative diabetic retinopathy. So the NPDR, that is non-proliferative type, it includes microaneurysms, dot and blot hemorrhages, hard exudates, soft exudates, and there will be intraretinal microvascular abnormalities can be also seen. And in case of proliferative type, there will be neovascularity at disc, and neovascularization elsewhere can be seen. So now comes the investigation part. Investigation can be done like color and red free fundus photography, OCT can be done, fluorescence angiography can also be done, and USG can be also done. So now comes the treatment part. conservative treatment can be done on the healthy lifestyle, diet, exercise, weight control, controlling HbA1c less than 7%. Anti-VEGF drugs can be given, that is vascular endothelial growth factor antagonist drugs like bevacizumab, aflibercept, and intravitreal steroids can be also given like dexamethasone, triamcinolone. The surgical part includes pan-retinal photocoagulation, which is done by double frequency Nd:YAG laser.